Hello and welcome. I'm Professor Shebu Orichabello, and in this lecture I'll be taking you through the penicillins, the family of antibiotics that truly launched the modern antimicrobial era. Over the next series of slides, I'll walk you through where these drugs came from, how they're built, exactly how they kill bacteria, the way we classify them, the spectrum of each subclass, why resistance develops, and how we use them safely at the bedside. I've packed in mnemonics throughout to make the material stick, and we'll finish with a couple of clinical cases so you can apply what you've learned. Have a pen ready, because by the end of this lecture I want you to be able to reason your way to the right penicillin for the right patient. Let's begin. Before we dive in, let me set out what I want you to take away. By the end of this session, you should be able to trace the origin of penicillin and explain the teat, lactam concept, explain the mechanism of action and why these drugs are bactericidal, classify the whole family into its 5 subclasses according to spectrum, recognize the main mechanisms of resistance, including how MRSA defeats us, anticipate the adverse effects, and confidently manage a penicillin allergy, and finally, apply all of that to choose the right agent for a real patient. Keep these 6 objectives in mind. Every slide that follows maps onto one of them. If at the end you can do these 6 things, you've mastered the penicillins. Our story starts, as many great discoveries do, with a bit of luck and a sharp, prepared mind. In 1928, Alexander Fleming returned from holiday to find a culture plate of Staphylococci contaminated by a mold, Penicillium notatum. Around the mold, the bacteria had been dissolved, a clear zone of inhibition. Fleming recognized that the mold was producing something antibacterial, which he called penicillin. He couldn't purify it though, and the work stalled for over a decade. Then, in 1940, Howard Florey, Ernst Chain and Norman Heatley in Oxford purified it and showed it could cure infection in animals, and then in 1941 in people, the Second World War drove mass production, and in 1945 Fleming, Florey and Chain shared the Nobel Prize. I want you to take away one big idea from this slide. Penicillin proved the principle of selective toxicity. We can attack a structure bacteria have, and we don't the cell wall. That a principle underpins everything else in this lecture. Before we zoom into penicillins, let's place them on the family tree. Every drug we call a lactam is defined by a single chemical feature. A 4-membered lactam ring. There are 4 major lactam classes: the penicillins, which are our focus today, the cephalosporins, like cefazolin and ceftriaxone. The carbapenems are big gun, broad spectrum agents like meropenem, and the lone monobactam, astrinum. They all work the same fundamental way, by attacking cell wall synthesis, and they all share the same Achilles heel. Enzymes called A-lactamases that can break that ring. Here's a simple mnemonic for the 4 classes. Please come cure me. Penicillins, cephalosporins, carbapenems, monobactams. Hold that family picture in your head, because the mechanism I'm about to describe applies to all of them, and so does much of the resistance story. Now to the chemistry. And don't worry, I'll keep it clinically relevant. Look at the structure on the left. The square drawn in coral is the lactam ring, a four-membered ring that's chemically strained, like a bend spring. That strain is exactly why it's so reactive. Its carbon-nitrogen bond springs open and latches onto the bacterial enzyme we'll meet in a moment. Fused to it in teal is the five-membered thiazolidine ring, which contains a sulfur atom. Together, these two fused rings make up what we call the 6-APA nucleus, the common scaffold of every penicillin. Hanging off the side in gold is the R group or side chain. Here is the single most useful idea on this slide. We make all the different penicillins simply by changing that one side chain. Change R and you change the spectrum, the acid stability so it survives the stomach, and the resistance to lactamase. And note where the arrow points. Dilactamase enzymes attack and cleave that lactam ring, destroying the drug. Keep that cleavage site in mind because it's the center of the whole resistance story. This is the slide to truly understand, so let me walk you through it step by step. Bacteria are kept alive by a rigid mesh called peptidoglycan, which is their cell wall. Building that wall is the target. Step 1. Penicillin diffuses through the outer layers to reach the periplasmic space where wall building happens. Step 2. It binds enzymes called penicillin binding proteins, or PBPs. These are the transpeptidases that stitch the wall together. Step 3. By occupying the active site, penicillin blocks transpeptidation, so the long peptidoglycan strands can no longer be cross-linked into a strong mesh. Step 4. The wall becomes structurally weak and the bacterium's own autolytic enzymes, its autolysins, finish the job by digesting the wall, and the cell bursts under its own osmotic pressure. So penicillins are bactericidal, meaning they kill, not just inhibit. But here's a crucial clinical pearl. They only work on bacteria that are actively growing and building wall. A dormant organism is largely safe from them. My mnemonic penicillin blocks the wall, then pops it. Bind PPP, block transpeptidase, and let autolysins pop the cell. Having seen how penicillins kill, let's talk about how we dose them, because this is high yield for exams and for practice. Penicillins are what we call time-dependent killers. The pharmacodynamic parameter that predicts success is the time that the free drug concentration spends above the minimum inhibitory concentration of the organism, written T greater than E9C. Notice what that means. It's not about how high the peak is, it's about how long we stay above the threshold. The practical consequences flow directly from that. First, we dose frequently, and increasingly we use extended or even continuous infusions to keep concentrations above MIC for as much of the dosing interval as possible. Second, most penicillins have very short half-lives, around 30 to 60 minutes, which is exactly why we give them several times a day. Third, against gram-negative organisms, there's little post-antibiotic effect, so if levels dip, the bacteria can start regrowing. Contrast this with aminoglycosides, which are concentration dependent. For those, the peak is everything. So commit this to memory. For penicillins, it's time, not peak. Let's start with the original article. The natural penicillins, penicillin G and penicillin 5, the crucial difference between them is the route. Penicillin G is poorly absorbed orally and is given by injection intravenously or intramuscularly for serious infections. Penicillin 5 is acid stable, survives the stomach, and is taken by mouth for milder outpatient infections. Their spectrum is narrow but important streptococci, including strep pyogenes and sensitive pneumococci, Neisseria meningitis among the gram-negatives, and classically they remain the drug of choice for syphilis caused by Treponema pallidum. So clinically you'll reach for them in streptococcal sore throat and cellulitis, in syphilis using long-acting benzathine penicillin G, in meningococcal disease, and for rheumatic fever prophylaxis. Their weakness is that they're easily destroyed by lactamyces. To remember the routes, I use G for grave, 5 for verbal. Penicillin G is given by injection for grave, serious infection, while penicillin 5 is verbal, meaning taken by mouth. Soon after penicillin came into use, Staphylococci fought back by producing an enzyme, penicillinase, that destroys it. The pharmaceutical answer was this subclass, the anti-staphylococcal or penicillinase-resistant penicillins. The trick is chemical. A bulky side chain physically shields the A-lactam ring so the staphylococcal enzyme can't get at it. The members are nafcillin, oxacillin, cloxacillin, and dicloxacillin, plus methicillin, which is now historical and only survives in the term MRSA. These drugs are narrow spectrum and used almost exclusively for methicillin, sensitive staph aureus or MSSA, think skin and soft tissue infections, abscesses, and endocarditis. Two clinical pearls. First, they do not work against MRSA because MRSA changes the target itself, making an altered penicillin binding protein called PBP2A. We'll come back to that under resistance. Second, anafcillin and oxacillin are cleared by the liver, which makes them convenient in renal impairment. To keep the names handy, I use NALDC to clobber staph, nafcillin, oxacillin, dicloxacillin, cloxacillin. Now we broaden the spectrum. The aminopenicillins, amoxicillin and ampicillin, keep the gram-positive activity of the natural penicillins, but thanks to an amino group on the side chain, they penetrate the outer membrane of several gram-negative bacteria. Of the two, amoxicillin is better absorbed orally, causes less diarrhea, and is dosed less frequently, so it's our oral workhorse for otitis media, sinusitis, dental and respiratory infections. Ampicillin is the intravenous option and has a special role against listeria and enterococcus. Remember ampicillin for listeria meningitis. The classic way to remember their extra coverage is the mnemonic HALPSS through Haemophilus, E. coli, Listeria, Proteus, Salmonella and Shigella. Two important watch-outs. First, they are still destroyed by lactamyces, which is why we so often combine amoxicillin with clavulanate. Second, a very testable pearl, giving an aminopenicillin to someone who actually has infectious mononucleosis from EBV produces a characteristic maculopapular rash that is not a true penicillin allergy. And note, no Pseudomonas cover here. Next up, the broadest members of the family, the antipseudomonal or extended spectrum penicillins, piperacillin and the older ticagrelin. Their headline feature is right there in the name. They cover Pseudomonas aeruginosa, a tough, often hospital-acquired, gram-negative that the earlier penicillins miss entirely. Alongside Pseudomonas, they retain broad gram-positive and gram-negative activity, which makes them valuable for seriously ill patients, sepsis of uncertain source, febrile neutropenia in cancer patients, and hospital-acquired pneumonia. In practice, you'll almost never see piperacillin alone. It comes paired with the lactamase inhibitor tazobactam as piperacillin tazobactam, affectionately called pip-tazo. That combination protects the drug and extends cover to anaerobes and many resistant gram-negatives. A word on stewardship, because pip-tazo is one of our most reliable anti-pseudomonal agents. We use it deliberately, not casually, to preserve it. My shorthand is pip-tazo for the sickest. We've now mentioned combinations several times, so let's deal with the lactamase inhibitors properly. On their own, these molecules have almost no useful antibacterial activity. The job is to act as bodyguards or sacrificial decoys. They bind irreversibly to the bacterial lactamase enzyme and disable it so the partner penicillin can reach its target intact. The four to know are clavulanic acid, avibactam, sulbactam and tazobactam, and each travels with a particular partner. Clavulanate with amoxicillin to make coamoxiclav, sulbactam with ampicillin, tazobactam with piperacillin, and the newer avibactam with ceftazidime for highly resistant gram-negatives. The mnemonic is simply tasty: clavulanate acid, avibactam, sulbactam, tazobactam. And I like that word because these agents cast a protective shield over the penicillin. But be clear about their limit. They restore activity only against organisms that resist by making a lactamase. They do nothing against resistance from an altered target, which is exactly why they cannot rescue us against MRSA. Let's run quickly through the pharmacokinetics using the familiar ADME framework. Absorption. Some penicillins are acid stable and given orally. Penicillin V, amoxicillin and decloxacillin. While others, like penicillin G, piperacillin and nafcillin, are given by injection. Distribution. They spread well into most tissues and body fluids, but they cross into the central nervous system poorly when the meninges are healthy. The clinically useful twist is that when the meninges are inflamed, as in meningitis, penetration improves enough to treat the infection. Metabolism. Most penicillins undergo little hepatic metabolism, the exceptions being nafcillin and oxacillin. Excretion. This is the big one. Most are cleared by the kidney, largely by active tubular secretion, so you must reduce the dose in renal failure. And the classic exam pearl, Probenecid competes for that same tubular secretion, so co-administering it raises and prolongs penicillin levels. Remember Probenecid as the drug that makes penicillin hang around longer. Antibiotics and bacteria are locked in an arms race, and penicillins face three main resistance mechanisms. The first and commonest is a lactamase production. Bacteria secrete enzymes that snip the lactam ring before the drug can act. This is the mechanism we defeat with the lactamase inhibitors we just discussed. The second is an altered target. The bacteria modifies its penicillin binding proteins so the drug can no longer bind well. This is how MRSA and many resistant pneumococci escape us, and crucially, adding the lactamase inhibitor does nothing here because the enzyme was never the problem. The third is reduced access. Gram-negatives can change their pour-in channels to keep the drug out or pump it back out with efflux pumps. Look at the MRSA spotlight on the right. Because it's high yield, MRSA carries the MECA gene, which makes an altered protein called PBP2A with very low affinity for all ag-lactams. That's why no penicillin, with or without an inhibitor, works against MRSA, and we must switch to agents like vancomycin, linezolid, or ceftaroline. Penicillins are among the safest drugs we have. That wide therapeutic window is one reason they're so widely used. But they're not without adverse effects. By far the most important is hypersensitivity, which ranges from a mild rash to life-threatening anaphylaxis, and because it's so central, I've given its own slide next. Beyond allergy, the common nuisance is gastrointestinal upset, and the broader spectrum agents can disturb gut flora enough to cause Clostridioides difficile colitis. A few specific reactions are worth knowing: acute interstitial nephritis, classically with methicillin and nafcillin, presenting with fever, rash, and eosinophilia, neurotoxicity with seizures at very high doses, especially when renal failure lets the drug accumulate. Rare hematological effects such as hemolytic anemia and neutropenia. And finally, remember that high-dose intravenous preparations are sodium or potassium salts, so they can cause electrolyte overload or hyperkalemia in vulnerable patients. None of this should make you fear the drug. It should make you prescribe it thoughtfully. This slide deserves your full attention because penicillin allergy is one of the most common and most misunderstood issues in clinical medicine. Hypersensitivity reactions follow the 4 Gell and Coombs types. Type 1 is IgA and immediate. Urticaria, angioedema, and at its worst, anaphylaxis within minutes. This is the dangerous one. Type 2 is cytotoxic and can cause hemolytic anemia. Type 3 is immune complex mediated, giving serum sickness and vasculitis. Type 4 is delayed and T-cell mediated, producing contact dermatitis and the maculopapular rashes that appear days later. To remember the 4 types, I use acid: anaphylactic, cytotoxic, immune complex, delayed. Now, cross-reactivity. The old teaching of a 10% cross-reaction with cephalosporins is overstated. The real figure is around 1 to 2% and is highest when the side chains are shared, mainly with first-generation cephalosporins. Carbapenem cross-reactivity is low, and Astrionum, the monobactam, is essentially safe in penicillinology. The bottom line, a genuine immediate. Type 1 reaction means avoid all lactams and reach for a non-lactam alternative. Let's consolidate everything into a practical bedside reference, the kind of table I want living in your head when you're on the wards. For streptococcal sore throat or cellulitis, reach for penicillin G or V or amoxicillin. For syphilis, it's long-acting benzathine, penicillin G for methicillin, sensitive Staph aureus skin and soft tissue infection. Use an anti-staphylococcal penicillin, nafcillin, oxacillin or cloxacillin. For otitis media and sinusitis, amoxicillin with clavulanate added when resistance is likely. Listeria and enterococcal infections call for ampicillin, often with gentamicin for synergy. For pseudomonas or undifferentiated serious hospital sepsis, piperacillin tazobactam. And for classic lactamase producers, including the mixed flora of human and animal bites, amoxicillin clavulanate is the go-to. Notice the logic running through the whole table. Match the spectrum of the drug to the likely organism and escalate only as far as you need to. That principle, not rote memorization, is what good prescribing is built on. Let's apply what we've learned to a real scenario. And this one trips people up constantly. A 19-year-old presents with sore throat, fever and swollen neck glands, and she started on amoxicillin for a presumed strep throat. 3 days later, she breaks out in a widespread maculopapular rash, and her monospot test comes back positive. The question is, what's going on with that rash? Pause and think before I answer. The key is the positive monospot, which tells us she actually has as infectious mononucleosis caused by Epstein-Barr virus, not strep throat. And here's the classic association we mentioned earlier. When you give an aminopenicillin like amoxicillin or ampicillin to someone with EBV mononucleosis, the great majority develop this characteristic rash. Crucially, this is not an IgE-mediated true penicillin allergy. It's a non-allergic virus-related phenomenon. The clinical lesson is huge. Do not reflexively label this young woman as penicillin allergic, because that label would follow her for life and push her toward inferior, broader, and costlier antibiotics. Document exactly what happened instead. Here's a second case that ties together mechanism and resistance. A 54-year-old man has a wound infection and the culture grows Staph aureus that is resistant to oxacillin with a positive C-foxitin screen. He has no drug allergies. The question has two parts. Why will piperacillin tazobactam fail? And what should we actually use? Take a moment. Oxacillin resistance with a positive C-foxitin screen is the laboratory signature of MRSA. Now think back to our resistance slidey. MRSA resists not by making an enzyme, but by altering its target, producing PP2A, which has very low affinity for all I-lactams. That's the crux, because the problem is an altered target and not a lactamase. Adding the lactamase inhibitor tazobactam achieves nothing. It's solving the wrong problem. So every penicillin, including pip-tazo, is ineffective. The correct choice is a non-T lactam such as vancomycin or linezolid. And if you specifically want lactam with the MRSA activity, that's the newer cephalosporin ceftaroline. This case is the practical payoff of understanding mechanisms rather than memorizing drug lists. Before we close, let's lock everything in with a rapid mnemonic recap. These are the hooks I want you to walk away with. Please Come Cure Me gives you the 4-8 lactam classes penicillins, cephalosporins, carbapenems, monobactams. High ALP CES captures the extra gram-negative coverage of the aminopenicillins. Haemophilus, E. coli, Listeria, Proteus, Salmonella Shigella, CAST is the 4A, Lactamis, Intidus, Imbitas, clavulanic acid, Avibactam, Sulbactam, Tazobactam. Acid lists the Gell-Coombs hypersensitivity types, anaphylactic, cytotoxic, immune complex, delay. Time, not peak, reminds you that penicillins are time-dependent killers. Efficacy tracks the time above MIC. And finally, altered PBP is not an enzyme problem. That's the one-line explanation for why MRSA defeats every penicillin and why lactamase inhibitors can't save us. If you remember nothing else from this lecture, remember these 6. Run through them tonight and again before your exam. And that brings us to the end. Thank you for your attention and for working through the penicillins with me. We've traveled from Fleming's contaminated plate all the way to the molecular reason MRSA defeats our best lactams, and along the way I hope the mnemonics have given you sturdy handholds. Remember the big themes. Penicillins kill by blocking cell wall cross-linking. They are time-dependent. The side chain defines the subclass and its spectrum. Resistance is mostly a lactamase or altered PBP. And a reported allergy always deserves a careful history rather than a reflex label. If you want to read further, the chapters on lactam antibiotics in Katzung, in Goodman and Gilman, and in Rang and Dale are excellent. I'm very happy to take your questions now. Above all, go forward and prescribe these remarkable drugs wisely. Antimicrobial stewardship is everyone's responsibility. Thank you.